Welcome to an information webcast with Generali PanEurope on the topic of absence management and the role that occupational health services can play within that. My name is Shane Martin. I'm a business development consultant with Generali PanEurope, and I'm joined by our guest, Dr. Robert Ryan, from one of Ireland's largest occupational health service provider, which is Medmark. We'll be discussing the topic, as I said, of absence management and how a robust occupational health service can play an important part in the absence management strategy. Dr. Ryan, thank you for joining us this morning.
That's all, pleasure.
And firstly, I'd just like to start off with just on a general topic in terms of how big an issue is absenteeism in the workplace, and how big a problem is that for Irish companies?
I don't know if I can speak to the scale or the extent of the problem, other than to say that we're an outsourced provider to a large number of companies, small Irish companies, multinational companies, public and private sector, and it certainly would be a key driver in them coming to the service, seeking help.
Okay.
So it's an issue that's perhaps never more relevant than now in terms of managing in a difficult economic environment, that companies would be coming to us because it's an issue they want to manage.
Yeah, and I know in terms of absence management strategy has many factors to it, and the occupational health service being part of that. But in terms of what, in your opinion, could companies be doing in terms of managing their absenteeism?
Yeah, I suppose the first thing to say is, as an occupational physician, I feel that the primary responsibility or ownership of absence management lies with the company.
Yeah.
Now we can play a part, but I think a company in addressing this issue needs to have good real-time data in terms of the absence levels. They need to have a fairly clear policy in place for how that's managed, and that includes things like how people notify the company when they're being off work, return to work interviews, training of supervisors, and doc health. So there's a whole variety of steps, largely under the ownership of the company, but where we can hopefully play a role in giving advice to individuals who are out of work, in liaising with the company when we identify barriers to return to work, and then providing information to the employer which allows them to manage the absence.
A lot of the primary management of the absence management strategy lies with the employer.
I think so, yeah.
But in terms of occupational health service, if an employer is doing all those things as like managing the data in terms of exit interviews or return to work interviews, in terms of an occupational health services, how can that complement what an employer might already be doing? Okay,
so our role is, I suppose, making contact with the individual who's out of work and entering a dialogue with them. And out of that, a number of things arise. First of all, we get an understanding of what's wrong with them.
Yeah.
We can ensure that or encourage them to make sure they're receiving appropriate care, get an idea of where they're at on the recovery, and then begin to talk to them about a return to work plan.
Okay.
And that can identify barriers to return to work, and if some of them are work related, we can talk to the employer, see if they can be removed. It also may be seeking accommodation from the employer in terms of getting them back to work, and perhaps phasing in of work or some simple workplace accommodation, and that also we can do. There are also occasions where we have resources, so if we see somebody in the company provides an employee assistance program, we might direct them towards that program so that they're supported. If it's an injury management issue, so if we're seeing somebody with an injury at work, again, we might have resources to assist them in the recovery, be it imaging or physiotherapy.
Yeah.
And ultimately, our role is to work with the company and the individual employee to find a solution.
Yeah. So
people tend to bring us problems, and we're trying to find a solution.
Yeah. And how important is just the conversation about a return to work strategy at an early stage in the absenteeism? How important is that in itself, just having that conversation?
It's very important because it first of all it gives us an understanding where the person's at in terms of their own expectation.
Yeah.
We then have an opportunity to share with them what we think would be a normal response to that particular medical complaint.
Yeah. And
sometimes we'd share with them information material, giving them an idea of what would be reasonable, and also maybe to dispel some of the myths that people can have. I must be 100% better before I can go back to work. If I have any ongoing symptoms, I must remain out of work till they're all gone. Work will be, will hinder my recovery. So part of our advice is to give them good information about their health issue, about how it would impact on their fitness work, and to encourage the normalisation of work and by and large managing the recovery within the context of work.
So Dr. Ryan, in terms of the reasons for people being absent from work, what kind of trends are you seeing at the moment?
We would audit a number of clients where we see their staff, and the same pattern emerges across most sectors, and that would be that the two largest causes for absenteeism would probably be mental health issues and musculoskeletal issues. After that, cancer and maybe cardiovascular.
Okay.
And after that you get a whole range of other medical things, but they'd be the top four, I would think.
So the cardiovascular and the cancer cases, from an occupational health service provider's point of view, there's maybe limited added value that can be added if they're already in the medical system. Would that be fair to say?
Yeah, we have less of a role in assisting them in the management of complaints. Our role really is to advise the employer about where the person's at and what the likely expectation is.
Okay. And in terms of the other two major areas, which is stress and depression and musculoskeletal, they're obviously areas that where occupational health comes into its own, maybe in terms of where it can actually add value.
I think so. I mean, I think if you look at those two broad categories, let's just take musculoskeletal as an example. Musculoskeletal is a common cause of work absence. It has a disproportionate impact on absenteeism because those who go out with musculoskeletal injuries tend to have, on average, twice the length of absenteeism for that cause than from other causes, and it's more likely to go on to long-term disability. Okay. So it's an area where I think there is a return on early intervention, on offering those individuals perhaps access to resources through an injury management scheme, relatively modest interventions, but ones that can alter the outcome. I think also the useful intervention there is if there is an aspect of their job, and it may be only one aspect of the job, which is proving a barrier to them getting back to work, then we can link in with the employer about ways of working around that to get them back in. The other key piece of value in an occ health intervention is just working with people so they have an understanding about how they might best manage their complaint. So the commonest example of that would be simple musculoskeletal back injury. Historically that would be managed through rest and inactivity and waiting for someone to be 100% better before returning to work. Now what we now know is that that's actually that's not in their best interest, and it's likely to prolong their recovery period of time and increase the likelihood of long-term disability. So part of our role there is just education, advising them about managing their back injury while remaining active. Yeah.
And in terms of, have you seen over, say, the last number of years how the approach towards early intervention, and I suppose in the approach of maybe being reactive as opposed to our companies now more and more looking at early intervention on a more proactive approach at a much earlier stage?
Some companies, and I think companies where they, if we're just talking about musculoskeletal here, I mean I think those companies who have identified they have a problem are more likely to be open to discussing ways of resolving it. And it's not necessarily a high cost intervention. Some of this is fairly low cost with the interventions I mentioned, and also feeding back to employers if there's patterns of recurrent injury that they can identify where they may want to alter how they do their work processes.
And how important is it from an occupational health service provider like yourselves when you get to see the person early in terms of influencing their thoughts and beliefs relating to their injury and in relation to what their expectation is in terms of potentially returning to work and what the time scale on that might be? I think
if I could put the opposite end, if we didn't see them, if someone was out of work with an injury, was symptomatic, was attending their GP, and perhaps at times relying on the public services to get access to physio and imaging, and it can be a huge delay. I think if we see them late, our opportunity to influence their behaviour, to assist them, to inform them, to work with the company is really gone. The situation has sort of like solidified, and the absence is going to be of longer duration.
And it's difficult to, I suppose, have an expectation for the employee of when they might return to work, in terms of in the short term, in the absence of early intervention, being proactive, it leaves a void maybe for other beliefs to exist within the employees.
And particularly coming back to that very long held belief, which would discourage physical activity while having any symptoms.
Yeah.
And we would provide them with information that would encourage them to revisit that.
Yeah, okay.
And to perhaps think about work as being part of the recovery rather than a long-term end point.
We mentioned earlier stress and depression.
Yeah.
What kind of trends are you seeing in that area? In particular, our experience would be work-related stress is being presented more and more as a condition for absenteeism. And
I think certainly anecdotally, HR colleagues in client companies would say that there is an increase in certification work-related stress. Probably two broad points to make there. One is, I think there is work-related stress. I think people have issues where they've got good pre-morbid personality, they're experiencing difficulties in the workplace, that's having a negative impact on their mental health. I do think, however, that they're the minority of cases.
Okay.
I don't think that the majority of certs that say work-related stress, in my experience, actually the issue is work-related stress. I would much more commonly see what I would term work-revealed stress.
Okay.
And it's no less real, and the person is no less in need of help, but it's arising within work but not caused by work. So, for example, it's not uncommon now for people to have financial difficulties, a long commute to and from work, issues of work-life balance, perhaps alcohol issues, perhaps pre-existing depression. There's a whole range of challenges that people experience. Work is the area in which there's an expectation that you will perform to a certain level, and therefore work is the arena in which those difficulties can surface and become revealed. But it's not really work as being the cause. And I think it's absolutely essential for companies to differentiate between the two, because where they have those cases where there is a work-related issue, the priority, and it would be an urgent priority, is to address that problem and really early to intervene. On the other hand, if it's what I would consider work-revealed stress, the solutions are different.
And how important from an occupational health service provider, we mentioned about musculoskeletal, getting those cases early is important. Similar on the stress and depression side, when it's a work-revealed case, how important is it that you see that person early?
Well, with anything, I think if you're not seeing them early, you're not in any position to influence the outcome in a positive way. So getting in early, following a conversation with an individual, might actually alter their perception of the problem that they're facing. It might inform them about approaches they could take to address it. Lots of companies have employee assistance programs, so it might get them access to support that way. It might also allow a conversation with the company, if the company can provide some input, not in a work-related stress format, but just recognising a staff member is having difficulty. So I think if you're not intervening early, you're really just in a very responsive phase, and you have to deal with what comes to you rather than having the ability to influence.
You mentioned a difference between work-revealed stress and work-related stress, and you mentioned about they will be treated, once identified, they can be treated differently. Can you give an example of how one might be treated versus the other? Well,
work-related stress attributes blame. It's essentially identifying that within the place of employment there is a stressor that is responsible for the staff member's ill health. And leaving aside what help the individual might need in terms of their mental well-being, the primary, I think, response of the employer is to address that issue. So it's got a very specific employer responsibility to recognise as a problem, make an assessment of it, and address it. The work revealed is not looking at that workplace as being the primary focus. It's really looking at the individual and identifying and working with them to identify the reasons why they're feeling unwell. And it could be a whole myriad of, it could be alcohol, it could be drugs, commute, childcare, pre-existing mental health, or a combination of those and others.
In terms of normalising some of those behaviours and maybe assisting that person, helping them their expectations and when they may get back to work, How important is that as a role?
So if we talk to someone and they're experiencing difficulties, leaving aside this issue of causation, it also allows a conversation with that individual. What is the nature of their complaints? How would we define the way in which they feel unwell? And practically, what measures could they take or have they taken to get into a better place?
Yeah.
So that could be medication, it could be linking it with their GP. Sorry, it would definitely involve linking it with their primary care physician. Yeah. It might be employee assistance program. It could be therapies, not just medication, but talk therapies.
Yeah.
And also maybe some practical suggestions in terms of if there were issues that were, causing their difficulties in the first place. So it's really it's a collection of interventions.
And I think from Generali PanEurope's point of view, in terms of being an income protection provider in particular, once those issues are being identified, we as an income protection provider can help maybe assist in some of those programs to assist in the person returning back to work.
Yeah, and I think when you look at that, that Generali intervention, it's really about having identified there's a psychological issue. What can we do? What can the employer do? What can the IP provider do to assist that person?
Yeah, come back to work.
And also, I think there's again a piece about getting the opportunity to share with an individual their normality of work and the potential benefits of work. And particularly with someone, if they have a psychological, if they have a mental health issue, work provides normality, distraction, collegiality, structure, and particularly if they have good colleagues,
good social
friends, supports, good management, it's a healthier environment, in my opinion, than being at home and the four walls and having the opportunity to dwell on the negative rather than the positive. So I think work, you can put forward work as a positive environment in which to recover, rather than being somewhere where you should avoid until you had a full recovery. Because the longer someone's out, it makes the barrier to return to work higher and higher.
Yeah.
So even independent of the medical complaints, if you take somebody out of work for weeks and then months, independent of what brought them out of work in the first place, the very fact of that length of absence makes a return to work ever more daunting.
So Robert, we've spoken about early intervention. How in your own practice have you actually implemented that on a day-to-day basis?
Yeah. Over the past perhaps year or two, we have tried to shift our model of practice from being a reactive service, where individual companies will bring us a problem when it has surfaced within the organisation to an extent that they feel they need to refer, into a proactive model. Now, the proactive model requires a change in approach. Firstly, it requires companies to have the capacity to identify at an early stage individual employees who cross over certain trigger points. So the typical examples would be someone who has 28 days continuous or cumulative absence in the last 12 months, or someone who's tipped over a certain frequency of absence. It's 4 or 5 absences of short-term duration. They are then identified to us as individuals that warrant OC health intervention. And clearly not going to bring everyone who crosses those thresholds into the surgery. So we have a team of nurses who will make initial telephone contact with the individual. And it's about doing all the things we discussed earlier: identifying the nature of the problem, their recovery, treatment, discussing a return to work plan, barriers to return to work, and agreeing a return to work program. And that takes care of the majority of individuals. And it's a very convenient, effective intervention. However, it does also surface cases that are perhaps complex, where, as we talked, maybe cases where there's lots of different factors, some employment, some personal, some health. And rather than, if you like, persisting with the telephone assessment, they get escalated to physician assessment. And also it identifies cases that may be contentious, where it's not possible to reach agreement on a return to work plan. And again, they're escalated to the physician. So there's a bit more time, there's face-to-face, and also allows the physician to engage with their GPs or treating doctors. So we've introduced that early intervention model for a number of large organisations, and certainly the feedback is positive in terms of the convenience, the efficacy. It's an appropriate tool to the task, and in cases where we've been able to monitor the response, it certainly has had a very positive impact on the absence levels, not by in any way, if you like, beating people back into work, but just working with them to create a dialogue and an expectation about what's reasonable.
And that obviously has an impact on the individual that has presented in terms of the absenteeism. What impact does it have in terms of the greater maybe culture within the organisation? That maybe has adapted that approach.
Yeah, well, I think if a company is seen to have very clear interventions and systems of assessing and supporting staff who are out of work, I think that not only does that influence the people who refer to the service, but I also think that it has an influence beyond those individual cases. For individuals who are out of work, they're aware that there's a process, that there are supports, there's accountability. So I think everybody working within an organisation will be aware of the changes and may moderate their own behaviour in light of that.
To what extent do you believe behavioural issues are a contributory factor to absenteeism in the workplace?
Yeah. Okay, so that's an interesting question. The traditional view, if you like, that there's a linear approach between what's wrong with you and an appropriate absence is too simplistic. It doesn't fully explain. Clearly there are occasions when someone who is ill is unfit for work, and there's no, if you're in hospital having surgery, you're not going to be fit for work. But outside of that, there's a wide spectrum of medical complaints, and also there are a wide differentiation between how individuals respond to that. So if you give 100 people the same medical complaint, they will be in or out of work to very varying degrees. And then you say, well, how does that come about? So the theory behind all this is sort of encompassed by what's described as the biopsychosocial model. So essentially it says individuals, okay, there's the medical aspect, there's a social aspect, there might be financial aspect, there are terms and conditions, there's employment aspect, there's a whole range of influences on an individual when they make that decision whether to be in or out of work. So it's not a linear relationship with what's wrong with you and and how long you should be out. So in many ways, the duration and extent of absenteeism is in large measure independent of the medical component. I mean, it's one of the factors, it's a key factor, but it's not the only factor. So it is on some level a behavioural response and influenced by a whole range of factors.
Yeah, and in terms of influencing the behavioural response, we mentioned about early intervention earlier, how that can be a significant influencer, and how whereby if the employee that's out sick gets to see the correct occupational health services, how that can influence their expectation in return to work. Is there a view out there that maybe some areas of in terms of GP services may have influence in the other way in terms of people's behaviour to their illness and absenteeism from work?
Yeah, I don't know. I don't know the extent to which would primary care colleagues or specialists, the extent to which they would view work as a negative in terms of recovery. So I don't have a sense that is the case, but I do know that if we get to engage with individuals early on, we can put the point across that work, the normalisation of work, and the normalisation of recovery within work.
Dr. Ryan, I'd just like to thank you for joining us this morning. I think it's been really informative, and I hope those of you who logged in found it informative. Contact details will follow on the slide afterwards. If you have any questions or queries, you can contact Generali PanEurope, or you can contact Dr. Robert Ryan directly if there's something we haven't dealt with that you'd like to expand on a bit further. Thank you.